Thank you, Carol. That was a wonderful presentation. I am very happy to be here, and I accepted the invitation as soon as I got this, because this is the area of interest to me, both in clinical and research areas. So hopefully we will be able to go over a few aspects of where we are in immunotherapy for thyroid cancer. Unfortunately, the data on thyroid cancer is not there yet. There are a lot of works being done currently. Most of my talk is focusing on how is immunotherapy being used right now for other type of cancers and where we are in thyroid cancer at this point. And again, if you have any questions, if this is too technical, it's very hard to explain the immune system in 1 hour. But if this becomes too technical, let me know, and then we can go over things together. The objectives of my talk from today is to summarize where we are with immunotherapy in cancer, to give you a brief overview of what a normal immune system is and how immunotherapy works related to that. What are the new FDA-approved drugs? And I can tell you this is a very active field. I've been away from office from 8 weeks, and I can tell you that many things have changed. I have to change my entire presentation last week. Actually, a new drug was approved yesterday at 4 p.m. Another combination was approved on September 30th. And so every day I get an email with, there is new drug approved for a different cancer. So this field is very active. I think I've done the most updated slides, but I don't know what happened this morning. If there was another one approved, probably yes. Where we are in terms of immune system in thyroid cancer, and is immunotherapy for thyroid cancer, are we there yet? So just to give you a brief overview, any type of cancer occurs due to 10 different backgrounds. There are 10 hallmarks of cancers, and we knew this from a very long time. In thyroid cancer, what do we know? Why does thyroid cancer develop? We all know about angiogenesis. We know how blood vessels can feed the cancer, and then cancer can develop and spread. We know that there are different pathways in thyroid cancer, namely MAP kinase and PI3 kinase pathways that are involved in thyroid carcinogenesis. We know there are different genetic mutations, including RET, BRAF, RAS, that can also result in cancer development and progression. And thanks to all of this research that I mentioned so far, we have gone from no drug to this menu list of targeted agents in the last 7 to 10 years. So there are a lot of research in the background, but these luckily translated from none to 4 FDA-approved drugs for thyroid cancer in the last few years. We all know evandetanib was approved for medullary thyroid cancer. Cabozantinib is now approved for medullary thyroid cancer. Both drugs showing a prolongation of progression-free survival in medullary thyroid cancer patients. Sorafenib was the 3rd FDA-approved drug for differentiated thyroid cancer. And most recently, lenvatinib was approved for differentiated thyroid cancer. So I think we've done a great job moving from research area and translating into targeted agents for treatment of advanced thyroid cancer. But as probably most of you know here, the responses to these targeted agents are only partial. They are short-lived. Everybody will eventually progress while you are on a tyrosine kinase inhibitor. None of these drugs have cured any patients with thyroid cancer to date, and we are yet to see any overall survival benefit on patients receiving these drugs. So we are now quite at a point where I think we still have a lot to learn in what we need to do in treatment of thyroid cancer, and the field, I think, is moving forward very fast. We now know that tumor cells are important, but there is a lot of things going on in the tumor microenvironment. And what does that mean? As you can see in this slide, very representative slide, the tumor cell is in green. It's just a very, very small portion of everything that is going on within cancer. There are a lot of things such as angiogenesis, new blood vessels that feed the cancer. But most recently, we realized that there are a lot of other cells, such as immune cells, lymphocytes, a lot of things that are either promoting cancer or they are not seeing the cancer in order to kill the cancer. And so most recently, in 2011, there was a new addition to all this menu of cancer hallmarks, and this was evading immune destruction. And I will try to explain to you what this means. What it basically means is that the immune system in the first phase is able to recognize and eliminate cancer cells. And this process right here is called elimination phase. So your own immune system is able to kill few cancerous cells before it develops. Then tumor cells that are not eliminated by your immune system continue to grow. And they reach a point where they escape your own immune system. So your own immune system is not able to see the tumor cell, are not able to recognize that there are tumor cells there. And so this phase is called the escape phase. The tumor cells are escaping the immune system, and now the cancer develops and spreads out. So this is a new theory that just recently was developed, and this is the basis of immunotherapy for cancer. And just another brief review of what a normal immune response is. There are 4 important components when you talk about an immune response. First of all, you have an antigen, and this can be anything, an abnormal protein, a virus, a protein released by the cancerous cells. And this protein is taken up by an immune cells in your body called antigen-presenting cells. And this immune cell is able to then interact with another immune cell called T cell. And the T cell is then going to the tumor and able to kill the tumor. So we have an antigen, we have an immune cell that takes up the antigen and presenting to the T cell, which in turn kills the cancer. Any questions so far? So,
I had one.
Mm-hmm.
On the previous slide, you had the CD8 T cell.
Mm-hmm.
I know that there's a bunch of them.
Mm-hmm.
Is that is that one in particular?
No, these are just general CD8 cells. We have a slide in closer to the end, but we know that the CD8 and CD4 cells tend to be the effector cells. You want those cells to be there to kill the cancer. There are other type of cells, such as regulatory T cells or other type of T cells that are more suppressive and dysfunctional. So an imbalance between an active T cell, which can be CD8 or CD4, and a suppressive T cell, it's what you don't want to see, and that's why cancer occurs. So what is immunotherapy? We are trying to teach your own immune system to fight the cancer. So this is a normal response, and now we are trying to intervene in different ways so that you get more of your own T cells being activated to go to the tumor site and kill that cancer. And how can we do this? There are many, many different ways to teach your immune system to fight cancer. And I know that many of you knows about giving interleukins and interferon in different type of cancers, giving vaccines which contains different peptide, giving vaccines with dendritic cells. And most recently, we've learned that blocking some immune checkpoints, such as CTLA4 and PD-1, or other immune checkpoints, can teach your immune system to fight cancer. It's going to be very, very difficult for me to cover everything in an hour. So I have chosen to cover what I am doing and what the area of my research interested is, and this is the immune checkpoint blockade. I'm not going to cover the vaccines or the T-cell cloning today, and hopefully if we have more data we can talk about that at a later time. Just to give you an overview of the immunotherapy history, in the 80s, we had a period of a very great enthusiasm of using immunotherapy. And at that time, they were using more vaccines, and the BCG vaccine was approved for bladder cancer. And then eventually, there were a lot of vaccine trials, which I don't know the details or how they were conducted, but I think we've learned a lot more since then, and probably they were not the ideal situation the way they were conducted at that time. But then afterwards, there was a phase where everybody was skeptical. All the clinical trials with vaccine didn't pan out too well, and so everybody was not too enthusiastic of continuing to doing this type of studies. Until 1990s, when Dr. Jim Ellison, who is now at MD Anderson and it's very well known in the field, received multiple prizes recently. But in 1990, he discovered a very important thing, and that's called an immune checkpoint, CTLA-4. And I'm going to discuss a lot about that in the next slides. But since then, there was a new era of immunotherapy, and I think this is going to be where we're going to move forward and what's going to be the most exciting period for the next couple of years. So let's talk about immune checkpoints. Okay? So immune system is very complex, but it's always on and off. So your normal immune system has these checkpoints in place. It's green light and red light. It's always, it goes up, it goes down, and it's always in check. It's always a balance between what's activated, what is not. If you have too many of the green light, that means your immune system is too high, and that means you're going to get an autoimmune disease. If you have too much of the red lights, your immune system has too many stop signs, then you develop cancer. Okay, it's always a balance, a green light and a red light, and we're going to talk a lot about green and red during this talk. So this is a menu of how many immune checkpoints we know about to date. And I can assure you that this list is expanding as we discuss today. But the purpose of this slide is not for you to remember. I don't even know them by heart. But it's just to show you that there are a lot of interactions between the immune cells and your cancerous cells. And two of these immune checkpoints are CTLA-4 and PD-1 interaction. And these are the two that are mainly studied and who were targeted by medications, and now those medications are approved. Most of the immune checkpoint blockades are not FDA approved. So in summary, what I'm going to talk today is what are the FDA-approved drugs for other type of cancers. We don't have any immunotherapy approved for thyroid cancer yet, but we do have an inhibitor to one of the immune checkpoint blockade called CTLA-4, and that's ipilimumab or Yervoy. We do have now two FDA-approved drugs that block the PD-L1 complex. This is another immune checkpoint, and these are Nivolumab and pembrolizumab. And most recently, the combination of the two, ipilimumab and nivolumab, has proven even better benefit, and so it was recently approved for melanoma. So this is where it becomes more technical and more complicated, but I hope I can get you through this very quickly. This is the two immune cells that I told you are very important for cancer. One is the antigen-presenting cells. The immune cells that takes the cancerous cells and present it to the T cell, which is the one that's going to kill the cancer. And what happens when these two molecules bind one to each other? This is a normal response. When these two molecules bind, what happens? T cell is activated, okay? And then it goes to the site and kills cancer. But we know that this immune checkpoint called CTLA-4, it's normal around in our body. When this T cell is too activated, it senses that, and it wants to put a stop on the immune system. So this interaction tells your immune system to go. But if it goes too much, then you're going to have an autoimmune disease. But now we have this kind of self-mechanism where CTLA-4 prevents that from happening, resulting in T cell inactivation. So it kind of puts the brakes on your immune system, okay? So you two receptors bind together, immune system goes up. If that happens, CTLA-4 comes into place and says, stop now. It's time to put a brake and go back into balance, okay? Is that clear? Having this in mind, what is ipilimumab? How is this medication used? So what we do, we give the ipilimumab, which binds to this CTLA-4. So what does this do? It takes the brake off the immune system. So when you give the medication, it binds to the CTLA-4. So this molecule cannot bind any longer to its receptor. And that allows for a activation, continuous activation of the immune system, and luckily tumor elimination. So you're basically trying to take off the brake of the immune system, increase your own immune system, and this way you fight cancer. So you are always on the go. When you give this medication, you cannot put the brakes any longer. Your immune system is always on the go. So ipilimumab, or Yervoy, was approved for melanoma. It is given an intravenous infusion over 90 minutes, every 3 weeks apart for 4 doses, okay? And with that, in 2010, we were very, very happy to see the results of this study, which kind of opened the field of immune checkpoint blockades. And this is again in melanoma. What you see here is an overall survival curve. And I don't know if I need to explain the overall survival curve to this group. Probably you've seen this type of slides all over again. But in the red line, you see the ipilimumab. And at that time was tested against a vaccine that was used at the time for melanoma. But what you can see is that 2 years, 24% of patients who had metastatic melanoma were still alive. But what's more important is the shape of this curve, not actually the curve itself. If you look at the shape of the ipilimumab curve, it never drops. So those patients who are alive at 24 months continue to be alive at 5 years. They follow this patient for 10 years now, and they are still alive. It's not only that it improves overall survival, but this overall survival, it's those people who had a complete response and a good overall survival continue to be alive with no cancer at 10 years. Yes?
They're no longer taking Yervoy?
No, they took it for...
It was just the one time? And
It's a 4-dose regimen. We don't know if those patients went on and received other treatments, but most of them received the 4 doses, responded, and then continued to be cancer-free for almost 10 years now, since the study entry at that point. So we do see complete responses in patients receiving immunotherapy. Like for targeted therapy, you rarely see a complete response. But in melanoma and prostate cancer, these are 2 examples of patients from clinical trial. You see complete disappearance of tumor. Now we are moving to another immune checkpoint, and this is the PD-1, PD-L1 complex. And what does this mean? When the tumor develops, it has this ability to express a receptor on the cells called PD-L1. So the tumor is very smart. It has this protein on its surface, PD-L1, and it binds to a receptor, to a ligand on the immune cell. And when that happens, when PD-L1 on the tumor binds to PD-1 on the T cells, the T cell becomes completely inactive. It does not see the cancer any longer. So it's the cancerous cells that makes this protein, and then the interaction between the cancerous cells and the immune cells makes your immune system kind of non-important any longer. It's blind. Everything is blind. So at this point, your immune system is in breaking mode, doesn't do anything, cannot see the cancer. This is the better way to explain it. Your own immune system is there, but it cannot see the cancerous cells. So what we are doing with this new immune checkpoint blockade with PD-1 and PD-L1 antibodies, we block this interaction between the cancerous cells and the immune cells. And by blocking this interaction, you then activate your own immune system again. So now you are on the go mode again. Okay, so now your immune system is able to see the cancer again and is able to fight the cancer. There are two PD-1 antibodies that are FDA approved. The first one is Nivolumab or Opdivo. It's approved for melanoma, those patients who already failed ipilimumab or already failed the first-line therapy with vemurafenib or dabrafenib. And it's also approved for lung cancer. Okay. This is also given an intravenous infusion over 60 minutes. It's given every 2 weeks. And this medication you give continuously. You don't stop. Okay. This is not like ipilimumab. You can give repeated dosage. And what do we know about this drug? How was this drug approved? First was approved in melanoma. And as you can see here on the left side, it was tested on a phase 3 clinical trial in more than 400 patients. And at that time, it was tested against the chemotherapy that was standard of care for melanoma. And what you can see here is that everything that's below the zero line, it's a tumor shrinkage. There was a lot of tumor shrinkage in this group that received nivolumab. But as you can see, this group here at the end is those people who had complete resolution of their tumor. It's 100% decrease in their tumors. So there are a bunch of people here at the end where you could see no cancer. What is also very important, if you can see the duration of response, how long these people responded to the drug. This is the nivolumab in orange. You can see that even at 1 year, not even 80% progressed. So the data is still ongoing, but the responses are very, very durable. You achieve the response, but then you have continue to have the response for a very long time. And this is the difference between what immunotherapy can do. The responses are not in everybody, but if you achieve that response is for a long time. If you look at overall survival, and this is something that we all always wish for and always hope for, to see an improvement, to see that patients live longer, you can see that in those patients who received nivolumab, the overall survival was much longer. And again, at this 1.5 year cut point, there were more than 70% of the patients that were still alive, compared with the standard of care where most of the people are already dead by that time. So the responses are not in everybody, but if you achieve response, that is very durable and people live longer. This is what we've seen with this type of drugs. Most recently, this was published maybe a month ago. We are trying to see ipilimumab was a great drug. We use it for melanoma, but now we have these newer PD-1 checkpoint blockades. Can we use them alone, or should we use them in combination? And so this was a phase 3 clinical trial in melanoma that included almost 1,000 of patients. And what they did was they gave nivolumab alone, ipilimumab alone, or nivolumab with ipilimumab in combination. And here you can see the responses. In the ipilimumab group, the responses were as we predicted. Around 15% of the patients responded to ipilimumab only, okay? In the nivolumab group, the responses were even higher. But what was very interesting is that if you combine the two immune checkpoints, almost everybody has a tumor shrinkage. And the median of tumor shrinkage, if you take everybody in the trial and try to average out of how much the tumor shrank at the time, was almost 60%. But more interesting is here at the end, again, there are a lot of patients who had a tumor shrinkage of more than 100%, which means the tumors were completely gone, okay? If you look at how long the responses were, you can see this, again, orange is the combination, blue is the nivolumab alone, and green is the ipilimumab alone. Ipilimumab did a great job in extending overall survival. You can, again, see the type of curve where at the end, it never drops. So what that means is these people who responded, they are still alive many years down the road. But what is it's interesting is that people live longer if they receive nivolumab compared to ipilimumab, but they lived even longer if they received the combination. And as you can see here, there are many still alive at I don't know what the follow-up of this was, but 2 years. So at 2 years, more than 50% of these patients are still alive. So great results. And then the combination was approved 2 days ago for melanoma. It stopped working. I don't know why. It's not moving forward. Okay. The same drug, nivolumab, is also approved in lung cancer. And again, this was a study done versus standard of care with chemotherapy. This drug was approved for melanoma and lung cancer this year, so very recently, both very recently approved. But again, seen in lung cancer was similar results. Here in this graph, you can see how long the response lasted compared to standard of care. So this is time. So if you had a response, that response continued to be present for many, many months. Also, progression-free survival was much different than standard of care, and overall survival was much better in the nivolumab group. So based on this trial, nivolumab was approved for lung cancer recently and now is being used. What is interesting is that a lot of research is now being done to measure the expression or the level of PD-1 or PD-L1 inside the tumor and try to correlate if you have PD-1 or PD-L1, is it more likely that this type of therapy will work for your tumor. But in this particular trial, they saw benefit regardless if your tumor expressed PD-1 or PD-L1. So it's a little controversial.
previous slide, are they, do they also have BRAF genetic changes and NRAS? And if so, have the designers of the study tried to look at that tumor makeup to try to identify which ones will have the most success?
Yeah, so very, very important question. The melanoma patients have BRAF mutations. Most of 60 to 70% have BRAF mutations. And so most of the thyroid cancer studies actually are just kind of, we are extrapolating from melanoma, what we know there. Because it seems like at the molecular level, the genetics of papillary thyroid cancer seem to be similar to melanoma, with a lot of BRAF being present. Most mutation you have in a tumor, the more likely you are to respond. Your immune system is going to recognize that. So the more genetic abnormalities, the better for your immune system to work. Lung cancer, on the other hand, has more of a RAS type of mutations. But we don't know in thyroid. I'm doing currently research in medullary thyroid cancer, where I'm looking at the immune system and mutation in medullary. What I have so far, I didn't see, these results are preliminary, are not released yet, but I don't see a much correlation between the RET and RAS with the immune system being activated, at least in medullary thyroid cancer.
In those patients that were on the left side that didn't respond with the drop, was there some kind of similar something that identified them?
We don't know. Yes?
Are these kind of results may be extrapolated to patients with metastatic disease?
They are all metastatic.
But I mean,
Oh.
are they seeing the results showing themselves not just in the primary site, but
In the metastasis.
like you have brain mets?
Yes, yes. It's all metastatic sites.
So, okay, so you would expect your brain mets to improve too. But it doesn't matter much how far advanced the disease is, you would expect to see some benefit.
These patients who were on this, most of these patients on immunotherapy trials were those who failed multiple line therapies, because by the time they were enrolling in these trials, people have failed the BRAF inhibitor or something else. Now, some of these trials, like this one, was a previously untreated patient, so they try to, now that they prove this is better than standard of care, now we are allowed to do clinical trials in patients who are not treated with anything. Before, we always have to prove it's better than what you have. And now that we've proven that, we are at the point where we can offer it and do clinical trials in patients who are untreated. So this was one of the first trials to look at patients who received this as a first-line chemotherapy, but they're all metastatic disease. And most recently, this is again last week, we have seen similar results using this drug in kidney cancer. It's not approved for this yet, but definitely there is an improvement in overall survival in kidney cancer as well. And I can tell you, I don't know of any cancer where this tumor is not being, these drugs are not being tested, or at least people are thinking to do it. Okay, so this type of drugs, you're going to see more and more results in all type of cancer, GI, pancreatic, leukemias. There is a phase 1, phase 2, or phase 3 clinical trial where any type of cancer is being tested at this point. Yes?
Are you seeing an increase, or have they not gotten that far, in then autoimmune diseases in these people?
Yes, yes. I will go over that in a moment. So again, we see complete responses in patients treated with Nivolumab. Tumors completely disappear. This is a patient with melanoma. This is a patient with renal cell cancer. And so great responses. But again, not everybody responds. Pembrolizumab or Keytruda, it's another blocker on PD-1 checkpoint. It is again approved for melanoma. and it was approved yesterday at 4 p.m. for lung cancer. And with this approval, it's only approved for those tumors that stain positive for PD-L1. So because they had to approve it for this type of tumors, they had to approve a test where you can test PD-L1 that becomes readily available. I'm yet to see that. I haven't used it. But now there will be an analysis available in some laboratories to test the tumor for PD-L1. Till now, it was only a research-based type of study. This medication is also given as an infusion over 3 weeks, and it's also being given repetitively. So the approval of pembrolizumab came after this clinical trial when they tested the pembrolizumab versus ipilimumab in melanoma. They used 2 doses of pembrolizumab, and this is what sometimes is being used to find out the best dose of that medication, and then you compare to what the standard of care is at that time, and ipilimumab was already approved. But as you can see, pembrolizumab was much better when it came to response rate, but also when it came to durability of response and overall survival. And the dosing didn't make any difference, so either you give it every 2 weeks or every 3 weeks, the results are the same. So they went with the approval of this drug every 3 weeks rather than every 2 weeks. So just to summarize on overall survival with this type of drugs, and this is a slide from Dr. Jim Allison. I told you he discovered CTLA-4, but this is what he always teaches all of us, and I think this makes a lot and a very important visual thing on overall survival. When we had chemotherapy, we were on this purple line. Overall survival was fairly low. As the line drops, that means that patients continue to die. At that point where it reaches this axis, so that means that everybody dies eventually, right? So with targeted agents, TKIs, BRAF inhibitors, we were able to shift this line. The overall survival is probably better than the basic chemotherapy. We shifted this line to the right, but it still touches the 0 point. So eventually everybody dies at some point. Nobody's cured. With single agent immunotherapy, we were able not only to shift the survival to the right, but move it up. There are people who survive and are cured, and they do not die, at least from what we have now, 10 years data. With the combination, what we see, not only that we move it to the right, but we move it even higher. So more and more people live longer, and many, many patients right now do not die from their cancer, at least from the data we have in melanoma, lung, and other type of cancer. So the hopes is that we can extrapolate all of this. We know that different cancers are the same when it comes to your own immune system. So we are hoping that thyroid is just another type of cancer, that can be targeted by your own immune system, and then we can see this type of survival curve in thyroid cancer as well. So to get to your point, this is where you give this immune checkpoint, you put your immune system on the go at all times. But this is what you do. You have more of the green lights at all times. So you are prone on getting an autoimmune disease. And this is where the side effects profile come from. Ipilimumab is much toxic than the other Nivolumab and pembrolizumab, but they can all come with a variety of autoimmune diseases, and it can attack any organ. Your own immune system does not recognize cancerous cells only. It can recognize normal cells and can attack from skin, can have rash and dermatitis. People may get colitis because it can attack the GI tract, can attack the liver, and people get hepatitis. inflammation of the gut, inflammation of the liver, inflammation of the lung, pneumonitis, more and more with the PD-1 than with the CTLA-4. Yes?
Did any of the patients that were in those studies already enter that study with immune disorders? And if so, how were, like, if they already had ulcerative colitis or...
You are excluded. People who had an autoimmune disease, most of them, they have a very thorough screen if they have an autoimmune disease. And most of them were excluded if they already had a problem to begin with. But these side effects can be very dangerous. There were we had people who died from their autoimmune disease. Their colitis was so bad, the diarrhea was so bad, the pneumonitis, inflammation of the lung can go very bad. But luckily, this is very infrequent, and the side effect profile is side effects are manageable by giving steroids. So you basically give steroids, which kind of suppresses your own immune system. And we thought for the longest time that you gave the immunotherapy, you increase your own immune system to fight cancer, and now you give the steroids, which are immunosuppressive drugs, so now you decrease your own immune system. So are we doing any better? Is the effect of immunotherapy now being weared off because we are using the steroids to treat the side effects? And again, recently, in the last 2 weeks, there was a very nice study showing that if you treat the if you treat the side effects, the autoimmune disease with steroids, the responses were still there. You can still get a response. You can still get a good overall survival benefit, regardless if you had an immune side effect that you needed to treat with steroids. So it seems that your own immune system is still able to fight cancer despite using the immunosuppressive drugs to treat toxicity. And I'm not going to go into a lot of details about side effects, but again, the side effect profile can be it's different between the CTLA-4 and PD-1. Some of them can be life-threatening, but most of them are manageable with steroids. And now when it comes to research, we always thought, okay, if there are tumors that have this, and we can measure if they have PD-1 and PD-L1, then they will respond to the drugs. And on the clinical trials, we saw that those tumors who have the PD-L1 or PD-1 responded better. But doesn't mean that those who are PD-L1 negative didn't respond at all. So what I want you to see here is a cohort of melanoma, lung cancer, and kidney cancer. Yes, you can see that if they did have the PD-L1 positive cells, they responded much better. For example, in melanoma, 50% responded if they had that particular abnormality compared to 30% if they didn't have. But it doesn't mean that the PD-L1 negative tumor are not going to respond. Okay, that's a very important point. Maybe they're going to respond better, but it doesn't mean that they're not going to respond at all. And actually, in kidney cancer, there was no difference. Regardless if you had PD-L1 or PD-1, your cancer still responded to immunotherapy. Overall response, depending on the drug, same thing with both Nivolumab and pembrolizumab. Again, these are targeting again PD-1. There is a difference that people respond better if they have the abnormality, but again, people who did not have still responded fairly well. So right now, except for the lung cancer that was approved yesterday, we don't use this as a predictor of who's going to respond or so forth. So now moving forward to thyroid, I think this area is still under development. We have a lot of things to work on thyroid cancer, but we are hoping that this is going to be just the first step in getting the drugs there. What I want to emphasize again is the immune system is complex. And to answer your question, Carol, from before, this is pretty much a list of the immune cells and how they interplay in thyroid cancer. There are cells like CD8 cells that are T helper 17 or different type of cells that promote tumors. If they are there, they'll make the tumor grow. There are other type of cells of the immune system that will kill the cancer. Or there are other type of cells that are just there, but they cannot see the cancer. They are very dysfunctional. And we talked about that as well. And so just to give you the concept of what we are doing is there are some cells that are very effective in killing the cancer, and these are the CD8 and CD4 cells. And there are some cells that are very suppressive cells. They are either exhausting in the battle with cancer or they are very dysfunctional. So there is always a balance in our body of how many of these suppressive cells and how many of these cells that kill the cancer we have. So cancer is, again, an imbalance. So if you test your tumor and you see that you have just few cells that are effective, like CD4, CD8, and you have a bunch of cells, like regulatory T cells, that are not able to kill the cancer, then probably that's the reason behind cancer development. And there was an attempt to look at papillary thyroid cancer, and Dr. French looked at 10 tumors. And what we saw is that this ratio between how many effective cells and how many suppressive type of cells we have correlated very well with the tumor size and with lymph node metastases. So if you have these imbalances, your cancer tends to be worse in papillary. But again, this was tested in only 10 patients. We also tested few patients for PD-1, and this is again in papillary thyroid cancer. Again, very, very few patients. But what you can see, if your immune cell have this PD-1 positive, which are those checkpoints that put your brakes off on your immune system, you see more lymph node metastases and you see more invasion. So it tends to tell you that if you have immune cells there that are exhausted, more likely your papillary thyroid cancer tend to be more aggressive. Again, very, very small series. And then Dr. Cunha from Brazil looked at several tissues, starting from normal thyroid to goiter to different type of thyroid cancers. And what they saw was that if your tumor is able to produce this protein, then it tends to be much more, it tends to be in higher frequency if it's cancerous compared in the normal tissue. Does it make sense? So it means that your cancerous cells makes much of this protein that in turn makes your immune system exhausted. There was a very small study in Germany looking at only 8 patients in medullary thyroid cancer. And what they saw was that compared to normal goiter, there were more Tregs, which are the dysfunctional type of cells, in those patients with medullary. And they looked in the tumor and in the blood. But again, this data is in very few patients. It's very hard to interpret in medullary. I think there is a bright future ahead of us. We have started to look into a lot of this immune system at MD Anderson. We understand now that this immune system is very complex. As I showed you, tumor-associated immune responses are now being tested in papillary, but we didn't know anything in medullary and anaplastic thyroid cancer. This is my trial looking at immune markers in medullary thyroid cancer, in all thyroid cancer, but focusing on medullary. And what I'm doing at this point is measuring the expression of all these type of cells, starting CD4, CD8, suppressive cells, PD-1, PD-L1, all the antibodies available, and tested to see what type of immune cells are present in the tumor. And I'm doing that across thyroid cancer types, and I'm comparing that with new mutations, with survival, with a lot of things. So we've done about 100+ cases to date, and the results will be available soon. But we are using very state-of-the-art techniques where you can take the slides, you can pretty much transform them in an electronic version, and I can then use my computer at work. This is a tumor where I can count very, very strict the amount of immune cells that are present in the tumor. We also have collaborations with immunotherapy platform where this effort that MD Anderson is trying to look for any particular changes in the tumor that is reflected in your immune system in the blood. So can we find something in your tumor and prevent you from going to any biopsies, and instead taking a blood test and looking at your immune system in the blood and correlate that with responses? So we are doing that in thyroid cancer. I've looked at 25 medullary thyroid cancer patients. The study is closed right now, but the data will be available in the next few weeks. So thanks to our donors, I have received an American Thyroid Association grant and a Bite Me Cancer grant to look specifically at medullary thyroid cancer. And so to date, I've looked at about 80 thyroid cancer patients' tumors, but also 25 patients' blood. And I'm analyzing the data as we speak, and I'm presenting these results 2 weeks from now. And fortunately, the commitment was I cannot release the results before that meeting where I have to, it has to be for the first time. So I will present the data in medullary in 2 weeks. Yes.
Are there other doctors that are also doing the same thing as you in other places in the United States?
There are efforts at the University of Colorado. There are a lot of people doing that there. I'm not aware of anybody else looking at this.
I think it's UCSF that is doing a Keytruda study on melanoma, but they've started admitting thyroid cancer patients and have seen some pretty remarkable results.
Yes. So we do have a lot of phase 1, phase 2 trials. I'm now collaborating with other departments to enroll a lot of our thyroid cancer patients in this trial, and we have enrolled a lot of patients with thyroid, but there is a lot of promising results, and so they allow us to enroll 20 patients in a study. Another, I don't remember the number, but many interest in enrolling a lot of thyroid cancer patients in already ongoing trials, and a lot of efforts in opening new trials, particularly for thyroid cancer patients.
My husband was enrolled in a new trial similar to the one that you mentioned, comparing his original tumor that was taken out 5 years ago with current blood markers to try to, that's at Sloan Kettering under Dr. Sherman.
Yeah. Was it the immune system? Looking at their immune system?
I'm not sure.
Yeah. Part of this study, we have looked at anaplastic thyroid cancer as well, and as you know, this is a very deadly disease, very quickly deadly disease. What we found here is that there is a lot of positive staining for these immune checkpoints, and I think that's going to work very well if you give this type of immunotherapy, because you do have the protein there, so the antibody can bind to it. Based on these results, we do send anaplastic thyroid cancer patients to our immunotherapy trials at MD Anderson. This is just an example where a patient received radiation to one of the lesions here, and then 4 doses of ipilimumab, and all 7 months later, all tumors disappeared. Okay, this is a patient who otherwise probably would have been dead in 6 months, and now at 7 months we see no tumors. Yes.
I have a question.
Mm-hmm.
My understanding is, with knowing that not everybody will respond, or some will respond and some won't, and not really needing to look and see if they have a PD-L1 checkpoint or whatever. That
Yeah.
And that is part of how they know that they have the responses, because the tumor is getting bigger because the immune system is
Yeah,
surrounding it.
yes. This is a very, very important point. And part of the first trial with ipilimumab, a lot of patients needed to come off the trial because tumors were growing, and we didn't know better at the time. And so they're using the same criteria, such as RECIST criteria we use for targeted therapy. So they measure the lesions. If it grows by a certain percentage, you come off the study. And what was interesting was that all the patients started to have a lot of growth of their tumors. And there were a lot of smart people who said, let's wait. Don't take them off study. Let's wait. They biopsied those patients, and then they waited. And then they saw a miracle. The tumors disappeared. And then when they look in more details, everything that was there, everything that was growing was actually the immune system going into there and trying to kill. There was no cancerous cells, but only very effective immune cells. And so we've learned a lot from the first ipilimumab study, where now we are even trying to modify the way we measure. We are probably not the best way to use the RECIST to measure. We are using immune RECIST, trying to kind of overcome this initial growth and allow patients to stay on the trial, knowing that probably this is a growth due to it's a good thing to have your immune system attacking that cancer.
We've got about 7 minutes.
Yes, and I'm almost done. So what I've showed you is that this immune checkpoint blockade can allow for durable responsive, improve overall survival. I think that all this, as I showed you, all these molecules act on a T cell-specific pathway, not necessarily on a tumor, but acts on your own immune system. So it has the potential to treat any type of thyroid cancer. We are not targeting cancer. So I think that it has the potential to even treat thyroid cancer, but we need to get the field moving quickly into that direction. TKIs, I've showed you, act on different mechanisms. Immune checkpoint blockades act on a completely different mechanism. So it may work while looking at combining the two together, or using the immunotherapy for those patients who have already failed standard of care with tyrosine kinase inhibitors. And what I believe is that probably immunotherapies may consolidate the responses. Then some people had to TKI into long-lasting remission. So even if you had the TKI failure, I don't know that for a fact, but it's speculated that maybe TKI itself can cause a more tumor death, more antigen release, and more even efficacious immunotherapy responses from that. So I think it's time to move into clinical trials specifically for thyroid cancer, but this is what I think we may start with. This is a vascular cell, a blood vessel. This is a cancerous cells, and this is the immune system. When you give any type of radiation, chemotherapy, or TKIs, you pretty much what you do, you allow for tumor to die and release a lot of those antigens, which in turn are recognized by your immune system. And if you then come with an immune checkpoint blockade, you can actually activate even more of your own immune system and kill the cancer on a different way. So either alone or in combination with different approaches, I think this is the way we should move the field forward. And again, I thank you for for the invitation and for being here. I have a lot of collaboration. I could have not done this without the help of immunologists. I'm not an immunologist. The immune system is so complex that it's going to probably take a lifetime to learn about it. But I have a lot of collaborators who have done work on immunology. I have received grant support from Bite Me Cancer, American Thyroid Association. I thank you, patients who come to us and allow us to take your tumors and look into it. And then that's why we can have all these drug approved and the field moving forward. But I think the future it's bright when it comes to immunotherapy in thyroid cancer, and I'm hopeful that very soon we'll have something open for thyroid cancer.